Thanks everyone for being here. We've done this new series of office hours with the presidents. This is now our third one, and we've had different topics for each one. And our goal here is just to try to help the membership navigate the current times. And tonight we're going to be talking about business of medicine topics. And I'm fortunate to have three members of the board here who are experts in the business of medicine. And that's Keith Sale, Bob Puchalski, and Alpen Patel. I myself am not an expert in the business of medicine. And so I will be asking lots of questions. And this is meant to be an informal way to help each other. And if people have questions, I encourage you to speak up or put them in the chat, and maybe Jamie could help us with the chat as well as questions come up, because I don't always see them. And so with that, thank you for being here. This is also being recorded so that if we do come up with some good information for our membership, we can also post it on the AAOA website and people can access it at a later time if they weren't able to be here tonight. So thank you all for joining us, and especially to Bob, Keith, and Alpen for helping me with these difficult questions. When we're talking about business of medicine, I think that the biggest challenge that we're all facing right now is with staffing. And I'm in a academic practice, and I see it, I think, just as much as anyone, that we have lost nurses, we've lost MAs, we're having trouble recruiting. And it's not just the fact that we've lost a number of them, it's also that the culture of what's going on, everyone's talking about looking at different jobs, leaving, going to traveling. We've had some of our OR nurses go and travel just down the street a mile away and come back. And it seems like there's a lot of stress just within the clinic about who's going where and when, and how short-staffed people are. And so I'm interested to hear just retention of staff and staffing issues. What are your experiences? And I'm not directly involved in the hiring and recruiting, but I definitely see that it's a troubling time for our practice. And maybe Keith, I know you're very involved in the KU system, and I'm sure you're hearing it every day. So can you tell us a little bit about your staffing experiences currently, what's going on and what you're doing?
Sure. Yeah. It's just like you said, we're really struggling like everybody else. And what's interesting is we've hired, I want to say 500 some odd people just in the last 8 months. Right. But the problem is our turnover rate is about 15%. Our vacancy rate is about 15%. So as fast as we get them hired, we're turning them over. And I think that is what a lot of people are experiencing. I think some of it is related to burnout, some of it is related to compensation, some of it's just quality of life, right? So for us, what we've been trying to do, number one for us was make sure that we're competitive in the market when it comes to compensation and benefits, right? I mean, you can't compete if you're not offering a salary that's competitive. So it's a little bit, number one is knowing your marketplace. I think most folks have a handle on that, but if you haven't addressed that in a couple of years, it's definitely worth taking a look at, because the numbers a little bit eye-popping in terms of what's changed in the last several years around salaries for any job type. The second piece of it is flexibility. Everybody wants flexibility. The one thing that the pandemic taught us was that you can do a lot of your jobs remotely. You can work from home. And healthcare is not any different. There are a lot of the things that our teams can do from home. And so we're trying to figure out how we can be flexible with all of our staff members and how they could have a day or even maybe two where they can do some of their work from home. So on a day where maybe I'm in the operating room, my nurse doesn't necessarily have to be physically in the clinic. She could be doing phone calls and doing EMR work from home for half a day or for the whole day. Now, obviously, that takes some trust. It takes some setup technologically, but I think it can make a big difference. The other thing we're looking at is part-time work. I think historically our organization has had a lot of folks who worked full-time, and it was the only option. You come in, you work 5 days a week, or we don't have a job for you. And that's just not reality anymore. People don't want to work 5 days a week. Even physicians, right? I don't want to work 5 days a week if I could avoid it. That being said, I think I work 7 days a week. It feels like sometimes, but I think ultimately, our employees want to have a little more flexibility, and so giving them 3-4 days a week as opposed to 5 days a week, maybe even offering early hours or late hours for some of those employees to do some of their work can be really beneficial. And so it doesn't mean the 8 to 5 is necessarily going to be the standard anymore. So I'm going to pause there though and see if Bob or Alpen have had some things they've tried in their practices to try and retain some folks or look for new folks.
Yeah, I can jump in. So our practice has got about 120 or so employees. We lost some through attrition through COVID, but we had to raise our hourly wage staff by about 18% actually in hourly wage payroll expense. That's between payroll and payroll taxes in the fall of 2021. So about 6 months ago or so. And our turnover rate is much higher than it was before, but quite candidly, we've always had quite a high turnover rate. I think that's kind of the standard in healthcare these days, but ours has been a little bit more acute. What we've done to try to mitigate some of that extra expense is to try to develop a middle layer of salaried individuals, give them some higher responsibility, and ask them to kind of be the backstop. And that's helped quite a bit because folks have been able to kind of pick up and they're somewhat incentivized to limit hours. And so even though we're paying higher wages, you can kind of be a little bit more efficient with payroll if you have somebody actively managing it and who's incentivized to do that. So that's kind of how we've come around. But it's still been very rocky. And we have had, I want to say, we lost 4 because of OSHA vaccination mandate. And then we've lost, I'd say, a 30% turnover in the last 2 years of our staff, at least.
Brutal.
A lot of retraining.
Yeah. And I think, one of the things that we've seen too, we've done a little bit of research with our HR team. That's one of the benefits of being in the health system. We do have some folks who are HR experts. And when you talk to them, and we do some of even our own exit interviews across the organization, the bulk of folks aren't leaving because of compensation. Some do, but that's not the main reason. A lot of times it is they're looking for that next step, right? What else can I do? And how can I expand my role? So it's either, that career ladder kind of approach. What can you do in your practice to give that person the next level up of experience, of practice level care, patient care, clinical care, whatever it may be? Is there a way that you've looked, Bob, to your teams to try and give them growth opportunities in your clinic? Is that something you guys do much of? We've certainly tried to. It looks like that is one of the key things to retaining people, is giving them kind of growth opportunities within their area of expertise.
Yeah, we try to promote within the group. So that all the mid-level managers there's been 7 mid-level kind of roles that have been developed since September, and all of them have been hired from within the group for a higher wage and salaried. And the key there is we found that those folks are working far more than 40 hours because they really feel as though they're part of the practice, and they feel as though there's a vertical path for them. So I think that's been helpful.
Where are you finding new employees? How do you go about finding new employees?
So I would say our folks get them from Indeed. So there's a lot of Indeed, and then we get a lot of folks who just bring over friends, and that's been pretty good as well. The problem with that is, and we used to have an anti-nepotism policy where you couldn't have any family, and we've migrated away from that because it's been so hard finding people. But the problem is with family, or even if friends bring people on, they tend to leave in groups too. So it's, they come on because one person likes the job and they tell their friend about it. But if if they're not happy about something, then it tends to kind of creep into other individuals. So we're doing it because we have to do it, but it's a double-edged sword.
For sure. Yeah, we've looked at, as an organization, looked at job fairs. And so I don't know for a lot of folks if there's an opportunity to go to some of the local colleges or nursing schools, if there's any close by, or if any of the community colleges are hosting job fairs. But those can be great places sometimes to find interested folks who are fresh out of training. Now, again, it means they don't necessarily have a ton of expertise, but sometimes we're finding those are folks that really you can kind of groom into really high quality staff if you can find them early. oftentimes we even do internships. And so we'll go to some of the nursing schools or the MA schools and ask folks if they want to do an internship with us. And so I think it's been really helpful. And Alpen, I don't know if you have thoughts on what you guys have done in your practice, or certainly anybody else in the group, please feel free to weigh in, just pop your hand up and we'll get you involved.
I don't know how much more I have to add, but I joined a practice probably just a few months prior to the pandemic, a small private practice of just really one other physician and 2 audiologists. We're fairly lean. We have 5 FTEs, and that includes our office manager, our surgery scheduler, our MAs, and our receptionists as well. We outsource our billing and collections. We have 2 full-time audiologists, myself, and then my partner. So, we've also had some good luck through Indeed and word of mouth through current employees. We've maintained essentially a core group of 5 MAs, receptionists, office managers, and surgery schedulers, and we've cross-trained everyone so that if one is out for COVID or any other reason, obviously another one can step in. And we've been blessed in the sense that although there has been an interest in increasing salaries for our employees, they also feel like they're part of the team, they're valued. I always thank each and every one of them every day when I'm working with them. So I think, the gratitude, I think, goes a long way, and they feel like, they're part of a good practice. And I don't think any of them are looking for other opportunities, but obviously with the current labor shortage and opportunities abound everywhere, I guess we could potentially lose someone maybe in the future. I just don't know. But so that's our experience in a small private practice group outside of Baltimore.
Thank you. I see that comment from Craig you're talking about, Jamie, where he talks about the idea of profit sharing with employees. And I think that's a really interesting concept. I don't, from an academic practice perspective, we don't really have that opportunity, but we do something similar in that we have kind of this middle management incentive program. We also can bonus our employees if we do well. And historically, when we were an individual department, we would do that if the department was doing well, and we would bonus individual staff and employees. Now that we're integrated as a health system and they're all system employees, that all goes through the system process. But I love the idea of engaging your team and being part of your practice. I think that makes sense, right? And they're accountable for the success in that practice. I think the only thing to be wary of is how you would unwind that, right? Once they're in, how easy is it for you as the practice owner to buy those folks out? If things go sideways, or if that employee needs to be let go, what happens to those shares? But I think that's definitely something that's very interesting idea, and I think something to consider.
The other thing I've heard out in the field is signing bonuses, but not necessarily, the bonus the day you start, but that you get the bonus after so many years or so many months or whatever the time frame is of being on staff. And that goes back to, the training time that goes into training somebody to onboard them. And then, the old HR role that, it's a 90-day rule for a reason. You don't want to get so far into the training that it costs you more to lose even somebody who maybe was mediocre at the job. But, a laddered bonus option is a way to consider things too.
Yeah, we've definitely done some retention bonuses as an organization as well.
We have as well. Recently, we've started doing travel bonuses, so something to offset the cost of gas for folks who are going to sites that are outside of our med. We have 10 sites, and if you're going to some of the more remote sites, you get gas reimbursement, which isn't taxed. So we'll reimburse you for that, not run it through W-2, and reimburse folks for their gas based on the mileage that they have between the home site and the other sites.
So have any of you guys had to change your practice at all because of your staffing changes, and reduce services or change what you can offer, or alter what you do in your clinical practices? So for us, I changed my practice significantly in that we're going to stop doing injection immunotherapy. We can't maintain, I know, right? We can't maintain in our academic allergy practice a reliable allergy nurse right now. And we're struggling to hire. And so as a result of that, we're going to switch to continue doing MQT testing, but really just do sublingual immunotherapy. And we're actually having to partner with our general, I say have to, but we're choosing to partner with our general allergy colleagues, and going to start to share practice locations, and they'll do our prick testing and MQT testing and injection immunotherapy. And then they'll also send us patients who are interested in sublingual. So it'll become more of a shared or blended practice to share in that nursing resource. The big benefit for us is it also helps with nursing oversight, nursing training, protocols, and alignment of some of those critical care pathways that are part of allergy testing, that as we've become a little bit more fragmented with our nursing structure in ENT, it's been harder to upkeep and harder to maintain that level of competence. And so for us, it's actually a really big win, but definitely has been a big change that we're going through as part of our practice. I don't know, Alpen or anybody else, if you guys have had to alter what you do in practice, what you offer, or if it's just business as usual still.
Yeah, I can speak to that. So we initially were doing skin testing and injection subcutaneous immunotherapy before the pandemic, and then once the pandemic came on, we suspended both, and now we're about to resume both the skin testing part. But like you, Keith, we're going to just probably focus on sublingual immunotherapy, not the sub-Q kind. And the other part that we've also been able to successfully launch during the pandemic is our sleep program. We're dispensing home sleep tests. I'm reading them, being board certified in sleep, and then trying to treat patients conservatively or medically speaking. And then, of course, if all that fails, talking to them about different sleep surgeries. So that's a new workflow or a new service that we've added over the last couple of years during the pandemic, and that's a growing part of our practice for sure.
Alpen, have you been able to dispense CPAP supplies like normal?
Yeah, no, so it's been a challenge because, as many on the call might know, there's been an issue with a major provider, the Philips Respironics folks, who have had a recall with their devices. So I've had a lot of patients who just want sleep surgery, said, just cure me, Dr. Patel. I don't want to go back to the CPAP I was able to tolerate for many years, but I can't even get a new one. So it's been a problem, but there are other manufacturers, and it's just taking a little bit longer, like everything else, right? So it's we've asked for patience from our patients, and some of them are getting their nasal and full face either auto PAPs, CPAPs, or BiPAPs, but just taking a little bit longer for the devices and then the accessories that go with them. And then, of course, some of them are just willing to go to oral airway appliances or sometimes more aggressive sleep surgeries.
In addition to the recall, we've had an issue with just getting units. So we dispense to non-Medicare and government payers, and we're limited to 5 a month. And it's based on historic norms, but those are debatable. But it does not meet the demand that we have. So we have a very long wait list, and we're forced to kind of triage off that wait list for CPAP supplies.
Goodness.
And who makes that number 5? Like, who's counting for you?
So it's the company. Traditionally, they want to try to avoid liability. So what they're saying is, hey, we don't want to play favorites, and we don't want to do anything that we can get sued for later, since these folks actually have comorbidities and could seriously get could sue the manufacturer in addition to the physician. So they're saying, hey, look, we're going to look back at this period. They use an index period, and they say, this is kind of what you used during that period, pre-pandemic, and we're going to stay within those bounds. And if you are a growing practice, then too bad, you stay within those bounds. If you've since shut down, they don't reallocate those, unfortunately, and they've been very slow to increase. So consequently, we've got a very long list, and we're trying to get folks, even if we usually try to keep all the private payers with us, and all the government payers, of course, we don't touch, but we're not able to go ahead and service the ones we have. So we've been having to get them off to other folks, particularly if they're truck drivers, or if they're going to lose their insurance soon, or if they have other comorbidities, or if they're AHIs are above 50. Right. So we try to prioritize those folks.
One of the other limitation of services I've seen is one of our colleagues in the AAOA is at another hospital here in town, and the block time in his OR is no longer because there's no nurses to staff the ORs. And so he now is having to take his cases to 3 other hospitals outside of Boston. And these are smaller hospitals, community hospitals that just happen to have some random time open. And he's taking his cases there. And I think that prior to this pandemic, he would never have thought of doing that. That was just like not part of the workflow. But he's going to have to find overtime wherever he can. And that's just it. And he shows up one day and figures out what equipment they have and hopes the image guidance works. And it seems like it's working. It just doesn't seem very convenient for anyone to, travel. Does anyone else have that experience with having to find block time because there are no nurses in the OR?
We've seen that for sure. Some of our practitioners have seen about a 15-20% reduction in their case volumes in the last year and a half. We're hoping to see a big influx. One of our biggest challenges actually is anesthesia providers, not just nursing. And we don't have enough anesthesiologists, don't have enough CRNAs, in addition to the OR staff. And so it's just all corners. And so we've got ORs. We have ORs. We just can't run them, which is doubly frustrating, right? When they're sitting there unused. And it's not unique to our hospital, at least in Kansas City. A lot of other hospitals have the same issues. But certainly, like you said, you worry about the quality a little bit, whether it be the equipment or the staff as you go to some of these other places that you're not used to going. So, but yeah, it's been a problem for us as well.
Our issue hasn't been block time. I mean, we've been able to keep our blocks. We just can't get the same throughput. So you just got travelers who come in, they have no idea what's going on. And it will take, you can't get your minors done. The larger surgeries, you're having to let everyone know what you need. You can't go to the doctor's lounge or go see a patient or make a phone call because you got to talk through what they're pulling and make sure they have everything in the room. And then inevitably you forget what you might need for a larger case. So that's been our challenge.
Your travelers probably come from Boston and are used to really long turnover times.
Our nurses are probably up in Boston traveling.
Really efficient if we can get the room going.
Yeah.
The things that we can't do, I guess it's a good segue to the next question about APPs, because, there's a lot of talk about APPs filling in for the work that we can't do. In the ORs, of course, they can't do that, and CRNAs can't do the job of an anesthesiologist. But APPs, I work with many great ones in my practice, and they often fill in for the volume whenever we don't have physicians available. But there's a lot of new changes that are coming or have come already regarding their licensure, as well as split or shared billing. And I guess there are two separate issues. One I can speak to is in Massachusetts, there was a recent bill last year that APPs can practice independently and be licensed independently. And so I know of some that are going out and opening their own practice, not subspecialty, but primary care. I have a patient who's opening their own primary care in the city as a APP, and it's allowable and fulfilling a need for primary care providers. And then I know that there's this proposed bill coming through about split and shared billing, which I can't speak to very intelligently, but I know that there are two sides to the issue, and there's going to be a lot of legal fighting about it. So I'm interested in anyone's thoughts here on the panel about APPs filling roles and split billing that I think we're going to see come to a vote.
So I'll start. I put this is probably, I don't know if this is legal or not, Jamie, so you can tell me if it's not, but I put a link in there to an article from our buddy Dan Shea, who actually had a really good summary about compliance around APPs. The big challenge that we see, at least in our organization, as we look at this, is if you use your APPs in a way that they are independent providers, it's probably not going to be a big issue for you. However, if you're used to using them where they do the majority of a workup or evaluation, you pop in and say, hey, how are things going? Here's the plan. Yep, we're all good. And then you pop out, but you bill under the physician, which you could do historically in split shared billing. That no longer is possible because it's going to come down to, much like the rest of our billing is time-based billing starting next year. Well, it'll come down to who spends the most time with that patient. So if your APP spends 51% of their time with that patient, then you have to bill under the APP, which means you're taking a 20% haircut on that E&M, right? And so again, that may be doable for a lot of folks, but for a lot of people, that's a significant cut in their potential pay from a visit. So if you're using your APPs like in that manner, is kind of a I don't know what the right word is. Some folks use them more like a clinical scribe, right? Where they go in, they take a bunch of notes, they write everything down, do the initial workup, do all the orders, and the physician just pops in and out and still bill to the physician. That's just not going to be possible a year from now. And so that may change for a lot of folks. If you're just doing them for post-ops, those kind of things, it's probably not a big issue. If they're practicing independently like they do in our practice, where they have their own day of patients, you may pop in and say hi to somebody, but they bill for it. I don't even charge for that. And so I think that's going to be an impact for folks who practice in that way. So just think about that if that's kind of how you choose to practice your APPs.
So in our practice, we've got 7 PAs. 2 are kind of more hospital walk-in clinic PAs, and the other 5 are assigned to a team. We'll, for the most part, use incident to billing with the underlying recognition that you have to kind of follow the Medicare rules from the incident to perspective. And so there are times where they'll bill independently when there's not supervision. But I'm frankly at a loss. I don't know. I was aware of the recent changes with balance billing, but I'm not aware of some change that's coming down the pike that's going to, is that something that's in CMS?
Yeah, CMS just this year. And so for this year, you can, and again, Dan Shade's article, I'd encourage you to read it, Bob. It basically highlights that if there's 2 ways to do it this year, right? And so Instant 2 really, I think, has basically disappeared. I think they got rid of that in late 2021. And there was no Instant 2 billing or no split shared billing for most of 2021. And then 2022, they started back with a split share, this new version of split share. And so, I think ultimately, right now if you can do it based on medical decision making or a shared visit based on 3 components. I think it's history and physical exam, history, physical exam, and medical decision making are the 3 components. And if as a physician, I do all of one of those, then it counts as the majority of the visit, and I can bill under my physician billing codes. If it is if the physician does only a part of one, so let's say I just have a quick conversation, but the APP draws up the plan, does it all, does the exam, does the history, I just add a few comments, but don't actually do the entire medical decision making on my own, then I can't bill for that. It has to bill under the APP. And so historically, there was a face-to-face component that was required, right? You had to spend some face-to-face time in order to bill as a physician under the physician. That doesn't exist anymore either. And so I don't even have to see the patient as long as I do one complete component, right? And so if the APP does the history and the exam comes out and talks to me and I develop the entire plan, the APP goes back in and takes care of it, you can still bill under the physician this year. Next year, the change is most of our E&Ms are going to, or I think all of them are going to time-based billing, right? And so as we switched and transitioned to time-based billing, the whole concept of medical decision-making and components of exam and history goes away. The idea being it lightens our documentation load. The challenge with APPs means it all comes down to who spends more time with that patient. And so if the APP spends the majority of the time with that patient, 51%, then you have to bill under the APP and take that 20% haircut.
15%, right?
I think it's 20.
Okay.
And is complexity still part of that new change, or is it just pure time?
It's pure time, starting in 23. Yeah, this year, that medical decision making has an impact, like I said, but after this year, again, so let's say you go in and do the history, the APP comes in and finishes the exam, medical decision making. If you've done the entire history, you can bill the physician. If you've done the entire exam, but they do the history and the medical decision making, again, doesn't make a lot of sense to do it that way, but who knows, right? The key is you have to do one complete component as a physician to theoretically bill for it under the physician this year for a shared visit. But next year, it's all based on time. And so that whole concept of what portion, exam, history, whatever, doesn't matter. It's just who spent more time with the patient, which again, I struggle with that only because, if in my practice, at least, I can go in and do workup and spend 15 minutes on a patient. It'll take my APP 25 minutes. not because she's not good at what she does, but it's just, we just process things and do things differently. And I have a lot different experience, background, and training than she does. And so no matter what, it's the same patient, but it's going to take her 10 minutes longer probably than it does me in an average clinic day. But we're somehow, I think, getting penalized for that a little bit, it feels like, based on this time-based billing process. So I think ultimately it comes down to, how you use your APPs, utilize your APPs in clinic, as well as in the hospital is a little bit more challenging, because there's some components about same group or not same group. And so we're, as an organization, trying to figure out, do we actually put our APPs under a separate tax ID and they become a hospital group, versus us as departments have a separate group, and then we both practice in an ICU, as an example, and can both bill for that care, as opposed to if we're together under the same group, they can't bill separate. Like right now, they can bill for a initial visit, and we can bill for initial visit as a physician, because they're considered two different providers. And starting next year, starting actually this year, you can't do that anymore. And if they're technically in that same group. The interesting thing is they say the same group thing, they don't really define what group means in true CMS fashion. So there's a lot of vagaries out there that you kind of have to work through and figure out what it means for your practice and how you work with APPs. In my mind, if you're practicing the way I would think an APP is intended to be practiced in conjunction with a physician, they have an independent practice, right? They are functioning as a clinician, taking care of and seeing patients to the level of their licensure. And if they're doing that and practicing that way, it really shouldn't have a big impact. But it's those areas, those gray areas where they're doing the majority of the work, but we're billing under a physician still, then that's where you're going to have some struggles, I think, starting next year when it comes down to time-based billing.
Keith, do you know if the APP needs to have a supervising physician? If you could do both, if they were not part of your group, if you could be supervising and at the same time a separate consultant on your own?
Really good question. And we're trying to work through that as well. There are, in Kansas, there used to be some laws around having a collaborating physician. And so, but much like, sounds like what you've experienced, some of that has gone away. There's not really that requirement as much anymore. We as a house staff or medical staff require a collaborating physician in our bylaws. And so we're trying to figure out, what does this mean for us long-term? Can you still collaborate, but not be in the same group, right? Can you be a supervising physician, but not technically be in the same group, even though you're seeing the same patients together? And so that's what we're trying to figure out. And that's where, like I said, the vagaries in terms of CMS's rulings may work to your advantage, because they don't define it. And so it may be possible. But I think everybody's laws are a little bit different around that.
I see a question there in the chat.
Yeah, to see it putting a time-based, he's just putting a cap or even a decrease on APP salaries. Where it's actually going to hit harder, I think. That's a fair question. It's certainly possible. I think it all comes down to how you utilize APPs. I think if folks have been utilizing APPs and in a sense double dipping, where you're both billing for a physician and APP to the same service and the same team. Yeah, I mean, and we're guilty of that. I feel like as an organization where we take advantage of the way you can bill now, and that allows us to both of our APP and our physician to bill at the highest level in an ICU on the same day. So there's a 99212 or 211. I forget the codes. I don't do that work, but there's a initial visit for the day or a higher level code for the day that they can both bill for currently. That starting next year, really starting this year, they can't do that together. One has to bill a subsequent visit code, which is a multi-million-dollar change for us as an organization, right? And so to your point, does that mean we change how we utilize APPs? And do we pay them less? Excuse me. I think that's a legitimate concern. Ultimately, it comes down to how you use them. I think you guys have to use them a little bit differently. And I think there's still a way probably to capitalize on their skill set and still maintain or generate revenue, but you may have to do it a little bit differently than what you've done it historically.
I apologize that I had to step away for a minute to get an on-call page. Did you already discuss the other question that I see posted in the chat now about equity share and retention?
Yes.
You did. Good.
Yes.
Great. So I just want to go on to the next question that we had in the list, which was touched on slightly earlier about working from home. And I know during the pandemic, we had most of our APPs and many of our physicians working from home. We recently brought everyone back more so than they actually wanted to. We actually lost a great APP who had been with us for many years because she wanted to spend more time at home and got used to it, has more children at home. And so it was unfortunate to lose her. And so there was a compromise that was reached where we allow them to work one day a week from home and do some telehealth and administrative work. And I'm still doing some telehealth. I do half a day every other week, and I find it very valuable for my patients that live further away. Does anyone else, Keith, you mentioned that you also saw that was somewhat of a retention thing with the staff having people do some remote work. Does anyone else have any experience with allowing staff to work remotely and maybe even themselves were working remotely?
We did it during the pandemic, but we haven't done it for probably about 4 months now, maybe 5. So we found there's animosity that was being created among the staff. Some were able to work at home, some weren't. The clinical folks tend to have to come in. That caused issues for us. So we just went back to all in practice. But we don't have that much demand for telehealth in South Carolina. I think it's really what your patients want. Our folks want to come back in. So there's very little telehealth that we're doing now. There was a lot during the pandemic, but very little that we're doing now.
I think the parking and driving in the city is definitely a barrier. Yeah. And people are coming in with more difficult problems. They would love to do it by telephone or video. And I know our preference is video over telephone, but we'll take whatever they're able to do. And for me, it's actually worked out really well. If I could see them, scope them, know what's going on, and then order some tests or imaging or medical things and do it by telehealth in a month or so, I actually think it's really valuable. I don't really need to take a look again. I can make a lot of good decisions and treatment. So it's sort of working out for me, and I enjoy doing it. I think it saves a lot, not just for myself, but also for the patients.
Do you usually do telehealth day from home?
I usually do, yeah. Yeah, it's sort of nice because the kids are not here. So it's the one day I actually get stuff done without being harassed.
When you guys do that, do you then have, is it a traditional visit where you have someone at the hospital or at your clinic who's rooming the patient and doing vitals or pre-work, or is it just a video visit, just you and the patient, that's it, nothing else?
Sometimes I actually have a student or a resident with me, and I could have a scribe sometimes if I want with me as well. And so they join in on the video platform that goes with Epic, but not a MA or someone other than that.
Yeah, see, we've set it up in a way that we do it like a traditional visit, in that our roomer goes in, gets on the call with the patient first, gets them set up, gets all they can do vitals from home, puts all that stuff in, goes to their med list, does all those kind of things, just like they would if they were face-to-face, and then logs out, flips the chart to say they're ready, and then the physician can hop in. So it really is for us a lot like just being in clinic. And then a lot of times our nurses will hop in when we're done and do education or training and then finish up with the patient. So for us, it's been great. I've done a few from home. I tend to do them from my office as opposed to in the clinic. Most of mine are blended. In my clinic, I do them at the start of the morning or start of the afternoon, because if I do them in the middle of my day, I just tend to get behind anyway. And so it ends up being late. And for whatever reason, when you're late to a telehealth visit, it is much more intolerable for the patient than it is if you're late to see them in your exam room. And so they tend to tolerate it much less on video.
So in that case, Keith, are your patients still doing it from home and the nurse or MA is intervening remotely or from your clinic?
We do, yeah. We have tend to be 3 different places. And so the patients are often at home. We are starting to offer telehealth in a business-to-business kind of a format where we contract with another hospital, rural hospital, because we have broadband issues in some of our rural areas, and the patients will come into the hospital in rural Kansas, where they can set up a video. They have an MA or a nurse in the clinic who will do vitals, who can do some exam work too. So we have some of the digital stethoscopes or otoscope cover or otoscope iPhone attachments. And so you can start to look in their ears or nose, actually do some of those those components of your exam over video, which has been really cool. And so we are starting to see some of the patients rurally come into their local hospitals to then connect with us, and see a lot of rural hospitals have interest in that with us as a health system. But
I have another question here in the chat. What do you find are high yield visits to conduct via telehealth, i.e. first visit after starting intranasal corticosteroids for allergic rhinitis or CRS? So I guess I can answer, for a new patient allergic rhinitis visit, it's actually reasonable for my patients to do the history, a really good history, and start medical therapies just based off of a telehealth visit. If it's a CRS visit, a first visit by telehealth isn't so great because I really want to look inside their nose and try to get an endotype and figure out what the real diagnosis or the endotype is. And so CRS is best for me in office, whereas allergic rhinitis is best for me by telehealth. And then in terms of follow-up, I think they're both good for follow-up. After I've done a good exam and endoscopy and know what's going on, I usually do medical therapy and then a CT scan. They can get the CT scan and follow up with me, and we can review it by telehealth. And I can also review the medical therapy. So for either one, and I primarily see those two as a rhinologist. So as long as it's not a new CRS patient, I think the other ones work really well. Nosebleeds don't work well for telehealth for me. They never have.
Mike, I also use telehealth for another purpose. So, obviously sometimes we order tests like you do, the CAT scan of the sinuses. In my case, a home sleep test, an audiogram after I've seen the patient, an MRI for whatever reason, and lab tests sometimes. So what I do at the end of the day after a full clinic is usually have 3 or 4 telemeds from the office and just go over those results with the patient, whether it's audio or audio video, using a HIPAA compliant platform. And I think patients definitely appreciate the phone call and just the information, so they don't have to come back in just for an audiogram result, an MRI result, a lab result, a home sleep test result, or in your case, the sinus scan. So yeah, I've been using it a lot just for, communicating results with patients.
Yeah, Alpen, my experience is like Keith's, whereas my clinics always run late, and then my telehealth patients are not very understanding when I'm late. Like everyone expects to come and wait to see me in the office, and they wait a long time and they sit there and they read a book. I would think that if they were home, they could do whatever they want. They're home and waiting, but they're not understanding. Right. How do you do it at the end of clinic? You just
so my clinic ends at 5, but it never really ends at 5, right? So oftentimes my telemed patients won't get called till the 6 o'clock hour or the 7 o'clock hour, and they're like, Dr. Patel, we thought you forgot about us, or we didn't get the link that you were supposed to send us. And I'm like, you know what? I'm sorry. It was such a busy day. But then they forgive me. And then they say, okay, let's talk about what the sleep study shows and what do I need to do? So, most of the time they will answer my call or my link that I sent them and set up the audio video. Sometimes I don't get through, and then I just reschedule them. But even my telemed appointment follow-ups are waiting 2-3 weeks to talk to me because I'm trying to limit it to no more than 3 or 4 so I can be home by 7:30 or 8.
Yeah, that's why I like to put them at the front of the clinic visits, just because that way I know they're usually fast, they're usually on time, and so I don't have a lot of delays then getting my face-to-face patients. But a lot of our clinicians will just do kind of like you do, where they block off a half day and just lock them, knock them off that way too, where they can stack up. If you're seeing 15 patients in a half day face-to-face, they can see 25 in a half day with telehealth, right? And so they can really stack up a fair number because they tend to be shorter, especially when you're doing things like you all are talking about, where it's just reviewing some results. It's a post medication evaluation. So I'll do it for that second LPR visit, right? If they're having that chronic globus sensation and cough, right? I'll do those, and that is a second visit. I'll do allergy second visits, test second visits. I'll do some post-ops. I do a lot of vagal nerve stimulator implants, and I don't even see those folks back after surgery anymore. They just send me pictures via my chart in Epic, and most of them do great. And if they have any questions, they always have a slot. They can always come in. We'll get them in. I've been doing them for 15 years, and universally, they walk in, yep, looks great, and you walk out. And so it's such a difficult visit for a lot of those folks to get in for that, that's been a huge win for those folks. I'm sure there are other areas for a lot of you that you might find work that way as well.
Yeah.
There's another question in the chat. Has anyone set up a protocol for using telehealth monitoring first sublingual doses? How do you adjust it during the pandemic? And I've experience with those. The first dose of sublingual is always in the office monitored. And the reason is because the on-label tablets say that. And so I do that just as a measure of safety. I've never seen a reaction from it. But I do think that telehealth is a really good follow-up sublingual, and you could definitely adjust doses. I check with them generally every 6 months and just adjust doses as needed. But that's much better than having them come in, because it's basically just a discussion that's needed for follow-up of SLIT for me. And then during the pandemic, there was that time where we stopped all immunotherapies. And so the only difference is that for SLIT, for my patients that were already on it, I really didn't have an escalation. I just started them back up full strength. And the reason is because I know they could tolerate it. And the FDA approved tablets, which are all high dose, don't have an escalation. And so I believed it was safe, and I didn't do an escalation. For shots, it was different. Any other thoughts about sublingual by telehealth from anyone else?
No, that's spot on. I agree with you 100%.
Great. Well, we have 10 minutes left, and there's one question on the list here that I think is a really important question that I want to get to, which is, what are you doing to reduce your and your team's risk of burnout at your office? And I read in the paper this weekend a nice article about nursing burnout and how Ketih mentioned we're losing a lot of staff because of it. Mm-hmm. Our measures of burnout at the hospital, the surveys that the staff is taking, that the residents are taking, it's all elevated. And I think that's a really important thing. And so looking for what are people doing to improve that, I can tell you that, the things that I've seen in the office is that there's more of those party social things, like baby showers have come back, and birthday party cookies have come back. And there's events that are being planned for the summer, even though it's not happening till the summer. It's something that people are looking forward to and talking about. And from a residency standpoint, we're also doing more social events. And I think just having things on the book and looking forward to things like the triathlon we're going to be running this summer as a group, and people starting training, I think that's just like really helping people to get back in the groove and the team. But to me, these are things that we've sort of always done to try to help morale. So what else are people doing to try to improve burnout and morale?
I'll start. We're not doing much, so I'll just be very honest. And I think it's we talked about it during our retreat, but there's not much that we've done. So we've kind of rolled right out of the pandemic and into just try to catch up mode kind of a thing. But I did resume quarterly dinners that I do with just my team. We go out to a restaurant, and I think that's been helpful. And it's been nice for folks to kind of be able to get together, like you said, for outside of work. But otherwise, there's not much that I can go ahead and share.
Yeah, for us, it's a lot of it is, like you said, Mike, is that social connectivity. It's not only the dinners that Bob's talking about. It's bringing in meals in the middle of the day. It's having snacks for no reason. It is trying to also listen to your teams about what they need. So for us, we start having regular team meetings and do huddle boards every day. We sit down and say, okay, what are the issues today? What happened yesterday? What worked well? What didn't work well? What do we need to fix? What can we make better for tomorrow for you? I think that's a big part of it. A lot of it comes down to a little bit of flexibility. Historically, it's been, healthcare is pretty rigid, right? It's you work till the work is done. And so it's reminding people that it's okay to take some time off if you need to go see take your kid to the doctor, right? Or to go see your kid in the play, or to, spend some time with your family. That's okay. And to some degree, for us as physicians, it means being aware of how we do and how we manage our practice. And so it's not adding that extra clinic day on a Friday afternoon just because you want to try and drive a few more cases to the OR in 2 weeks at the detriment of your team who's been killing it all week and just wants to get out a little bit early on a Friday. Now they're there till 6, right? It's just, I think, some awareness. And the last piece, is what I think it was Alpen who made a great point of this. It is just for our department, we have a big department. So we have 23 physicians, 5 APPs, and probably another 65 staff right across the organization. And half the time we don't even know their names, right? At the front desk, people don't acknowledge the front desk staff or the MA staff. And so those little things, and thank you for being here today. Thank you for helping me today. Those go a long way. People feel a part of the team and feel connected, like there's something that's good that they're a part of. That is one of the biggest drivers of job satisfaction and retention, is just feeling like you're part of the team. And so I think going out of your way to identify those folks who may not feel a part of the team, or making sure all of your staff feel part of the team, is really important.
I don't know how applicable it is to a private practice, but I could say our hospital hired a social worker who specializes in wellness. And she meets with our residents once a month. It was once a month for the first year. Now it's once every 2 months. And she's wonderful. She's a wellness coach. Sometimes I see her walking around the hospital with like a bag of like Halloween candy and just like handing out snacks. But she has a scheduled meeting with the residents, and each meeting is different. One's on healthy eating, that's without the snacks. One could be on yoga, and she does like an hour of yoga with them, or an hour of meditation, or like all the topics of wellness. But my residents love it. And will it be effective in doing what's intended? I don't know, but they really do enjoy it. And the hospital's making a big push. And I also think it's nice that they know that the hospital is making really big efforts to help all the residents in these ways. I don't know how you can implement something like that on a smaller scale, because this is a full-time person who's only tasked with doing that. Excellent. So do we have any other questions or comments? Thank you all for attending. We got some great discussion here.
I got a quick question while we have a group together. I'm curious if folks are wearing masks in the clinical setting universally. It seems that certainly the CDC guidelines are what they are, but there seems to be some variability in South Carolina. Is that the case in other parts of the country as well, or are we seeing pretty much universal mask all the time, every day?
I wear a mask every day, all day.
Staff as well, though, is what I was referring to.
Everyone in the hospital is required to wear a mask. Everyone who walks in is required to wear a mask. 100% of people in the hospital have a mask on the whole time.
Yeah, we're the same way. It's the hospital policy hasn't changed anywhere in any of our clinical settings. It's a mask and actually still eye protection. So I have the eye shields and a mask on every day. All the patients still wear masks. All of our staff still wear masks. I see a comment in the group about eye masking and will likely not stop. But I do think it's fascinating. You can always, I feel like, count on getting sick a time or two in the winter months. A lot because we see a ton of people coming out that are sick all the time. Not that we didn't do proper hand hygiene before and other things, but I don't know. It feels like having that mask on has definitely made it so I don't get sick as much. Not saying I got sick all the time before, but I do feel like there's something to that a little bit. But I am like our person on a Zoom chat here that I don't know if I'll stop wearing a mask in clinic. I think I might take it off when I'm not seeing a patient in the exam room, but at some point, but right now we're required to as well.
Interestingly, the news here, because pollen counts are high in Washington, yay, they suggested that if you weren't wearing a mask because of COVID, you may want to bring it back to help reduce your allergy symptoms. And so,
Right.
So you may see more wearers now as a result of that, or you may get those same questions when they come into your office.
K95 for allergies or COVID, you pick.
Well, this has been great. This was a great discussion. Thank you all for being here. And one last comment I want to take here. Thank you, Heather. Had a comment about wellness. Staff wellness, we shut down the office half day Friday every month, with 5th Fridays to do team building with all staff. That's a great idea. It's probably not all months that have a 5th Friday, but when you do, it's definitely something to look forward to. But thank you. That's a great idea. And so
I think that's a really good way to think outside the box. I know it in the long run, it will actually probably pay big dividends, and you will probably do better and have higher productivity from your teams by taking some of those days off and taking them to your team. So kudos to you. I think that's great, Heather.
Yeah, I agree.
excellent. So thanks everyone so much for being here. We look forward to seeing everyone at the basic course this summer. and have a great spring. Try to stay away from those allergies.
Amen.
Take care. See you,
All
everyone.
right, good night, everyone.
Great. Thanks, everyone.
Yeah.